Dr. Guha, Ash Guha, heart failure specialist and directs our transplantation heart failure. Dr. Goel, director of our structural heart, and there is a reason for get all these people there in 20 minutes. And then Casey Kappenman, who I cannot thank enough as I started with for putting this whole thing together here. Kuram, you and I will stay here.
Sure.
And this is about collaboration. And each one of you is being exposed to things that were not here 5 years ago. They were not here. We didn't have much registries. I mean, the most registry we had was a database, maybe an echocardiography or an CT, and you had to manually pull it. So now we have this amazing capabilities to be able to do that. So the first question is probably to Steve and you, how can we tap it? You know, the individuals are there. How can we tap these data? I mean, hurdles, opportunities, whatever.
I'll take first. One is, of course, you know, we have this immense data registry, data lake, which is an EMR digital twin, which has tremendous capacities where these registries can literally be generated in weeks and months rather than years within this umbrella. The key thing is needed is infrastructure. I don't think so the computation is at this stage an issue as far as practical for our colleagues in cardiology. The real issue is the bottleneck is experts, the computer scientists, the data scientists. Kudos to our small team of 2 data scientists, helped with 2 data scientists part-time by Dr. Steve Jones, that has not only built but continue to grow and has delivered so much. And with our partnerships, that's where the basic bottleneck is. We need more data scientists and experts to help tap and manage, but also we need domain experts to come in because it is an interplay and a collaborative project. It cannot happen just with the data scientists alone. So we need the domain experts.
But if you don't identify any, you're not going to get served well.
Yes.
Right? So see from your end, which really is a big data for our whole institution. So how do you manage it? How do you get to?
I'll take one from Ellen and then we'll...
So the mentor, how much will matter do you relate to this Vascular? I think we're highly definitely, i.e. that means huge option.
Yes.
Yes.
But I don't know about the second hand, where we are positioned versus other institutions in terms of
Okay, so I can tell you that we're not far behind. And actually, the key components that would be needed for a strategic, I would say, success, we may have those components much more than other institutions. For example, the HDSA, which can securely access, and we have gone through the process and the regulation and an ability to tap into that. Most institutions don't have that. And when I go on a roadshow, they are amazed at what we have been able to do that. Where we lack as compared to other institutions is partnerships and an ability in our own data science experts and partnerships. Those institutions have a lot of that, but they don't have access to data. We have a lot of data and access. We don't have a lot of expertise. And the key thing that we also has for success is a whole process where there is a team, the DIOP and the innovation, which actually vets all of these products, take them to test them, discard that doesn't need, and adopt. This is one of the main reasons where 95% of the digital products fail. So in essence, we have the right structure. We just need the investments in the right people, computational, and the partnership that hopefully will come through RISE.
Steve, before we go on, please, how do we tap big data, which is even bigger than in cardiology?
Yep, I imagine
we're ready for.
We're very close. Dr. Zog was asking about like how do you get to these resources? You can knock on my front door. It is email chcsa@houstonmethodist.org. You start there. If you can't remember that, just remember my name. Just email me, and we'll walk you through the process for the practical side. Now, also to your question and Dr. Lumsden's, where are we compared to other institutions? We're not on the bleeding edge. We're, I don't know, a couple steps back from the bleeding edge. There are a number of institutions ahead of us, no doubt. The ones the Mayos, the Harvards, the Stanfords, the Intermountain Healths, Duke. But we're not that far behind. All things considered, there are many, many, many other healthcare organizations that are much further behind us. Some of the things that we have that make Methodist and the data sets that we have access to unique is, you may remember, Dr. Thompson, it was probably 10 years ago now, we first introduced MIC to the organization. MIC is a Medical Informatics Corporation, and they built a system that ingests all the monitored bed data, all the waveforms, all of it, the vital signs, art lines, EKGs, anything that's absorbed from those monitored beds into a massive data set that is now over 10 years old, and it is probably the largest in the United States. What Herm was mentioning on that is like, great, you got this big mountain of bits and bytes, but what are you doing with it? So and that's where we're talking about. Okay, let's bring the clinicians to the bedside, into the room with the data scientists. The clinicians ask the questions, data scientists can help get the answer. Where we're behind is the bandwidth of the data scientist level.
Let me say along these lines, Steve. Methodist, even from a healthcare point of view nowadays, you have a button that records everything. It is people who ask the question, particularly those of you who are in heart failure, intensive care, et cetera, et cetera. I mean, this is available for you. So I would urge you, if you're not knocking on the door, somebody within your team.
We're not.
You're not.
I can.
You're right. So this is a question for both of you and Ash.
So
is how do we, looks like the data is there, go mine it with asking some very pertinent questions.
I want to, so we've been working on it for almost 3 years, but I want to mention here why Khurram's initiative is so different is I think the use of NLP, because we tried it with another organization just based on ICD codes.
Go ahead and, so for people who may not speak all the abbreviations, because NLP,
natural language processing, where he was able to actually use that to pull echo information from the notes, because the registry that we are building is Advanced Heart Failure Registry, which is almost done, and hopefully we'll submit some abstracts to AHA. But it was really, I think, revealing to us across the system in terms of how the outcomes were. These are really sick patients, because these are patients whose mortality is almost, 30 to 50% within the first year. And it was really, I think, for us revealing that, how many were actually getting referred to an advanced heart failure program or to a palliative care physician, so that, goals of care were discussed. So I think there are a lot of system-wide improvements what we can make, but I think that's where we are with that registry now. Now that we've built the registry, we've figured out, what are the patient cues that we can use to pull those patients. How do we go to the next step where we can incorporate an actionable alert? These epic alerts, there are thousands of them. People just keep tapping and no one pays attention to it. But how do we create an actionable, process where the patients are actually impacted?
Right. Let me just jump in real quick, because I think it's very important, because Ash, I think you jumped past probably 2.5 years of your frustration and limitations to get to where things were. And I think it's really important as we look at some of these things, and I think kudos to the team and all the work that you've done, because when you look at phenotype, and you would think that being able to find a heart failure patient in an EMR record should be very simple to do. I mean, you would think, if you, as a clinician, you think they have heart failure, there's an echo, there's some meds, there's some lab work, that should be one of the easiest to find, because it's, it's defined, a lot of it, especially if you're looking by reduced EF, by a test. The amount of work that these individuals had to put in to be able to create a system to accurately identify that, to me, was earth-shattering. The first kind of models that went through were so far off. They were just finding old, obese people. Great. That has nothing to do with what I'm looking for. And so I think that it is for people like me who are a little bit naive into this process, sitting back and learning all the steps that it went through to be able to do that. And I think people have really highlighted is that interface. And so because you have clinicians who kind of have a question, and we've got data that probably has the answer, But the problem is bridging that.
Yep.
And also bridging to even know how to ask the question. And I will take it back to, maybe a little bit of TMI, but I remember being back in one of my first advanced calculus classes, and you're trying to work the problem. And I went to see my tutor and they were like, go ahead and start. I was like,
Where?
that's the problem. I don't know how to start. And they're like, well, go ahead and start and I'll help you. And I'm like, and I literally walked out of that session being more frustrated than when I went in, because I literally did not know how to start the equation.
I mean, the beauty is that we have the experts here, at least for those of you who are interested, obviously, the experts here to how do you start navigating. The other thing is ask the right question, whatever question is, whatever is pertinent, right? And two, be patient, because it is not, oh, I have this question and within 2 days, I'm going to give you the registry and everything else. So you got to work with them, because what Steve also mentioned is what is the validity of whatever you're tapping, and you want to make sure that's valid. So be patient, but the data is there. The question is, how do you tap it?
And I think it highlights just the amount of resources that is needed to tap it. It's not just getting the data, but like you said, the data scientists and the interface to be able to get those moving forward. And Ash, I'll let you go back to it.
So I would just like to add, again, whenever I hear Khurram and, his team speak, I learn something new. And, this is an incredible amount of data and work that you guys have put in. So kudos to you. And, I'm glad to hear that, Cindy and Ash have already gone through the frustrations over the last 3 years. So hopefully my frustrations will be a little bit less. And I can learn from them and others.
Different. He said different.
Different frustrations. Yeah. But so my question, Khurram, to you and Dr. Jones and to Dr. Zogby is, obviously from a structural standpoint, we want to build a system-wide structural valve intervention registry, where we want to understand, patients that are referred, just like heart failure, patients who are referred to the valve clinic, patients who are not referred, what are the barriers. We know from other large data sets, including Harvard, that, only about 1 in 3 patients who are eligible or should have transcatheter valve replacement, aortic valve replacement, actually end up getting it. So there is a large proportion of patients that are not referred, and, we don't really understand why. So this is a very, potentially a impactful project where we can understand why these patients are not referred, who these are. There could be some geographical or geospatial limitations to these. So, we would like to build some of these, and some of our fellows are working with you on this. What are the barriers to development of this, and what are the ways in which Methodists can help us develop and build this?
So, very quickly, I think so. One of the emerging fields is phenotype refinement, as what actually is the phenotype we're looking, because that is the hardest part. Once you have done that, all the data pre-baseline and prospective is all available to link. You can identify alerts and everything to do that. Now, as you pointed out, what is needed from an institutional standpoint, I see there is a lot of investment in translational and basic science that happens internally. I think so the next frontier is data science, where more institutional investment as far as internal grants and things that needs to happen. And of course, partnership with RICE and folks like with Dr. Sabharwal.
Talking about partnership with RICE, Dr. Sabharwal, tell us where you see this. Obviously, you have a full department of computational engineers, electrical engineers, you name it. And you have tremendous power. I know you're not in the medical field, but this would be an amazing partnership. I know you and Khurram and the whole institution, both institutions are geared toward this collaboration. How do you see it? Where do you think the impact's going to be? What would it look like?
Think so. Methodist. So we at RICE work with basically the whole med center. So we are the Switzerland of engineering here, because we get to. It's a good thing we don't have in med school. So, but I guess the way I describe how the opportunity lies is that you all should have an engineering school without having one, and we all should have med school without having one. That's what I hope this will look like. It'll be melded so well that our folks will be on campus. They will learn things. They will work with you all, and that's where we are headed. That's the design of the whole institute, joint institute, which is happening now. In terms of having worked with pretty much everybody here in Houston and some organizations outside Houston, Houston Methodist actually has some really unique digital assets. And I think it's good to know what you all have, which is very, very unique. Nobody else in the world has that. And two of them are real-time assets that were mentioned here, which was the virtual ICU and then the acute care, the biointelligence. So nobody in the world has deployed them at this scale for this long. And then the part which is actually not being emphasized and is really crucial, that for these two assets, especially virtual ICU, whatever algorithms or machine learning predictive you develop, you can deploy them at scale. And that is a unique opportunity, which is, many times we do some analysis, we write it in a paper, and typically that's the end of that particular idea. To take it into patient care, deploy them so that it's available to everybody, that requires a whole new level of work, which often most institutions do not have access to. They can get data, they can do analysis, they can write a paper, and that's typically the end of it. So I think the ability to go all the way is also a unique asset Methodist has. So I think we could build on those, and those could be the first places where we can build global leadership. It is not, and I think everybody else would follow. The part of the big data, I think I would emphasize that is really important. We at least get 50 projects going, in my opinion, 50 data science projects going, where you all come with hypotheses. Some of them were just stated here. We match you with the folks who can make it happen. There's a lot of talent on campus. There's a lot of hungry people who want to aim, engineers, statisticians, AI folks, who want to work on problems with you all, which have a direct impact on healthcare outcomes. We also many of us happen to be Methodist patients. We would like to improve our own care. And I think there is a genuine interest in many of us to be a part of the solution. So I think my job from right side is you all have ideas, I will connect you with someone who is the right fit. And that's basically what I'm seeing happen.
That's beautiful. I'm so glad you mentioned these two unique opportunities. They are indeed unique. And you can compare it to pre-button, pre-virtual IBs from a historical perspective or whatever it is, but these are unique. And I would urge our physicians who are interested in such, to tap on them. Dr. Benfer, maybe some of your perspectives on this from a surgical perspective, postdoc.
All right. So I'm going to talk from a postdoc's perspective. Usually the postdoc is like the person on the field, right? The PI usually has an idea that they need something done, usually doesn't know how to go about it. So the postdoc is the one who has to find out how to get that done. And as postdoc, I guess collaboration for us is pretty easier in that we usually amongst ourselves. I sit in a working space where I have neuroscientists around me. On the other side, I have cardiac imaging. I have heart failure postdocs around me and whatnot. And we get to sit down together to have lunch, and that's when we have a base discussion. So collaboration starts from there, right? Getting interested in what other people are working on, and then you get to find out there are some ways in which we could actually collaborate, and that is how I start from there. Also, one way of collaborating is, for instance, I've had to work with the HDSA on some projects. So usually start from, okay, my PI telling me we need to get this done. I don't know how to go about it. So I need to find out how to go about it. I asked somebody, hey, have you done this before? And how do you go about it? Oh, yeah, you need to talk to Dr. Jones, for instance. So I emailed Dr. Jones, and then it goes on from there. We set up meetings, and we try to get the data that we need to do the work that we have to do. So for me, collaborating as a postdoc is all about getting interested in what other postdocs are working on, trying to find out common grounds, areas where their research could be of interest to you. Before I end this, so the frustration that I have had with maybe trying to get data is usually with a turnover time. And I know, Dr. Zogby, you mentioned being patient, maybe 2-3 days, but I've had instances where I've had to be patient for a very long time. I mean, months.
I didn't say patient at Methodist hospitals.
And for me, at that time, I would really love to be able to do things on my own. I know they just one body with everybody else going to them for the same kind of things, same kind of problems we have. So I'm like, in what ways can we probably empower those who are working or train them to be able to get some of this data themselves, if it is going through Slice Dicer in Epic to get what you need, or using the business intelligence website to get what you need. Most postdocs out there have no idea how to go about these things. It will be great. I don't know what HDSA can do to help postdocs out there who are actually doing the work to be able to work on some of these things.
Yeah,
Really good points.
well, Casey, along these lines, some perspectives. As you know, Casey oversees our research activities in the Heart and Vascular Center, has been a great addition to our team, you know. I know you've learned on our job here, although you've been in Houston for some time, few things of how can we help individuals navigate conceivably, just like was mentioned now, some guide for postdocs of how do they navigate the system, et cetera, et cetera. From few things from your perspective where you see some of our investigators struggling or something that you could help them with.
Yeah, I think on our side, one of our overall kind of philosophies is to stay out of the way as much as possible. But it's
Not completely out.
it's not as easy as I would hope. These innovations, these changes that AI is bringing to healthcare, how we're handling imaging data, each one of these is bringing a wake of questions behind it regarding regulatory compliance, risks, contractual legal terms, and the RI is really trying to get its arms around it. I really feel that the RI leadership is aware that things are taking too long in some instances, in some departments. And I would just say there's a lot of activities and a lot of efforts going on in those areas, specifically about projects that are using data and when we're trying to use data that's already here in different ways. One thing that our department could use, as I think it's more of a practical matter, when we're applying a research protocol, if we could have a good idea and a good understanding of that data path from start to finish, who's going to be involved, where things are going to be transferred to, and the data and what the data is itself, the more that can be explained in IRB's terms, in layman's terms, where we can understand and translate that information to the other departments in the organization, those conversations and questions are going to move faster, and questions will be answered quicker. So that's one thing. Like when we're writing protocols, if we could be more practical about how we're using the data and explain that, I think it would go a long ways. And then operationally, our department, working very closely with Dr. Cheryl Palmer, we are trying to be more smart about the operational data that we're swimming in day to day and month to month. We're trying to understand more about how long trials are taking, for example. The RI is taking that very seriously, and they're setting out an overarching goal to get study startup times down to 13 weeks. That's the goal. I know we're not there, but we're taking a lot of steps to map our internal processes, control what we can internally. We're digitizing our internal processes, and we're pulling that data out into dashboards that we think will answer questions a little quicker in meetings and to the different audiences like yourselves. So we are in partnership with you 100%, and we'll be working with postdocs and all the other faculty within the Heart Center to hopefully walk together and get these projects moving forward.
Thank you, Casey, for all what you do. I know it's not an easy one, but I think having these goals, yeah, go ahead.
Having been on many part of IRBs across all organizations, and I notice here the folks when they write IRB, and actually it's true for everywhere, are taking a guess, what should I write so that it will go right? And I think it's, and especially with data, it's a little bit complicated, as you noted, and I'm not trying to minimize that. I would recommend one idea would be to have at least 2 or 4 standard templates. Like if you follow these steps,
You request data, you store it here, this is how you compute. These are the people who will do it. And if there are a few templates which are successful, I would say ask people to choose from a template. And that makes it easier. And fill in the boxes. Then the other side of this equation becomes easier.
And that's great because we are helping with some of our templates with other divisions of what we have built the registry. So you're absolutely
Very good. That's a great suggestion. John, you've been patient.
One thing that occurred to me listening to this group and listening to great presentations is we do have the opportunity to lead medicine here. And there's something we are missing. I mean, we have a great system that you set up, Steve and Kurt. We have outstanding clinicians who are great at phenotyping. And we have a great partner with Rice. What we're missing is a scientific workforce that is going to connect all of those folks. I think we've done great program for a T32 training. Let's get an NIH training rate. Let's get some a scientific workforce in here that can help realize stuff that we want to do next.
absolutely. That's computational biology.
I think that would certainly would be an aim. I talked about it sometime, but I think it's maturing nicely to be. Alan, you want to say a few words?
I personally don't know the data scientist or computation guy. Tell me, educate us, number one, what those people are, and are they available? Is this money or is this talent resource? Both of you.
I would say data scientists can go the spectrum of data engineering / analytics, computational scientists, more advanced computational analytics. We need a mix of both. These people are hard to find, but from school coming that can become a pipeline, you can always do that. Resource is definitely an issue that Steve can talk about, which is definitely our bottleneck here.
Yeah, great questions, Dr. Lumsden. As a hiring manager trying to hire the people that we're talking about here, our competition is Wall Street and mostly Wall Street. The really good candidates that we've had on the hook, I mean, I can't compete. They're getting salaries that are twice as much as we offer at base, and then $100,000 signing bonus, and they're 23 years old. And we're also looking for people that and I want to place this out there because we're using the word data scientist like it's generic term. We're looking for healthcare data scientists. There's a difference, and the main thing is that, and I think Ashley will agree with me on this, is that the healthcare part of it. What does that imply? It implies that you have an understanding of what healthcare data looks like. I know you guys understand this, that Epic is not a giant spreadsheet. We're not waiting for, I just need these rows snipped out of it and give it to me. It is not like that. There are 77,000 tables in that thing. It is not readable by a human being. And that's what takes so long. And all the work that Herm and that team had done is to stage a billing system, which all EHR is a billing system. So their first function billing, second function billing, and third function billing. So what we're having to do is, but the data that is in the EHR for the clinical workflows that we're throwing in literally as an afterthought have tremendous value and tremendous knowledge and information in there that is untapped largely. So what our teams have been doing is refactoring that data into a nearer to research analytics set, completely different design than you would have for EHR. Believe me, I'm like a cyborg. I've stepped on so many landmines, I'm all blown to bits because I was a EHR vendor in former life. So the challenge is the people, because can we find them, Alan? Yes.
Yeah.
It's passion driven.
Yeah. Okay. We give you a mind, whatever it is. Say it's $150,000. Here's the person. I want them to primarily work on CV surgery related things. You can have the 20% of the time. How are you going to deploy them between Rice and this organization?
Work in progress. And teams are being worked out. I think so. There is going to be tons of opportunities, and the digital health institution would likely facilitate some of those, because most of the data scientists and engineers we want within our own ecosystem just because of the access. But at the same time, want to have them a foot in the Rice where this wealth of expertise that lies, that, as I said, we want to tap into that. So the processes are being developed. I promise we'll have an answer in a couple of months.
Okay. Let me read one last example, and that is something that Bright alluded to that I completely missed, to be honest with you. What he said was, yeah, I was asked to do this. I didn't know, so I went and talked to the heart failure postdocs. So, yes, there's an ecosystem up on the 5th floor, 6th floor that I actually realized existed, that the interaction between these postdocs, by housing them together, they start help one another. And so, number one, is that something we can elaborate on. One of the projects that we gave to Rice was the dreaded HELA kits. You guys love all this. The physicians, we got to move from passive resistance to active participation. So a palette of these computer vision cameras in the operating room, which monitor everything that we do. Now, we just submitted the first abstract validating nurse-based observations with computer vision cameras, and the correlation is phenomenal. That means we don't need the nurses to do that. So every time one of these new sensors, and you got to give Roberta a lot of credit, and you mentioned the virtual ICU, that was universally despised by most of the clinicians when it started, to be honest with you. But there's such an opportunity there. It doesn't replace the bedside intensivists, but it does augment a lot of things that we do. We kind of need to see each one of these new sensors. It's a giant opportunity for us to define, and I think that is the area that we are the lead in.
So that's why we want to call it augmented intelligence. That's really what I'm asking.
All right. One other thing is that, which I think was mentioned, sorry to interrupt, but there is a chance of doing science, which I think people alluded on. When you have this much data, there is a chance to generate new hypotheses of what's happening. And that requires a very different thought process, scientist thought process. I think just to add to why is it hard to hire data scientists in medical organizations is actually also not just the money. They actually do not have a career growth track. Like if I go to Google, I could be CTO one day. But if I come to Methodist, I will be an engineer for the rest of my life, right? And I think that realization is very important because they can do it for 5 years. After that, they will leave.
Yes.
So I think unless we build, why as an engineer, I'll go to right because I have a track. I have a career growth track here, right? And I think it's NYU med schools and others have figured out that they need to provide engineering faculty. MD Anderson does it well too, in my opinion. Ability to grow in their career and do bigger. I do think it's important to look at those models and kind of be inspired by that.
I mean, these are very important points and a great lens that you see it differently, and indeed it complements all the other issues and opportunities that we have. So for the sake of time, I want to thank our amazing panelists and speakers for a great discussion. Thank you very much.
He's talking.